Today, we're diving into a world that is truly at the edge of what's medically possible. We're talking about anesthesia for pediatric heart surgery. And let me tell you, this isn't just adult surgery shrunk down to a smaller size. Nope, it is a completely different universe, full of unbelievable complexity, precision, and, of course, incredibly high stakes. Let's get into why.
You know, this quote from the source material really just hits you. It perfectly sets the stage for what we're about to discuss. We are literally talking about taking the smallest, most fragile patients you can imagine and putting them through physiological conditions that are almost unthinkable in any other part of medicine. It's a field that is absolutely defined by its extremes.
All right, so to really wrap our heads around this, we're going to walk through 4 key challenges. First, we'll look at the biologic extremes that truly make this universe apart. Then, we'll get into the paradox of the pediatric heart itself. After that, we'll dive into the wild extremes of cardiopulmonary bypass, and finally, we'll tackle the last major hurdle, weaning the patient off that very life support.
Okay, so let's kick things off with just how extreme we're talking. See, pediatric heart surgery doesn't just work within the body's normal rules. For a few critical hours, it completely rewrites them.
To really get what extreme means here, just look at this list. Surgeons will cool a child's body all the way down to 18 degrees Celsius. That's about 64 Fahrenheit. Their blood is often diluted by more than half. And in some procedures, they actually stop all blood circulation completely, sometimes for up to an hour. I mean, think about that. These are conditions that would be absolutely catastrophic in any other situation, but in this operating room, they are necessary for survival.
So why all these extremes? Well, it's because of the second major challenge, the unique physiology of a child's heart. And it's a real paradox. It's this tiny, high-performance organ that has almost zero backup capacity. And this is the key thing to understand. A kid's heart is not just a miniature adult heart. The biggest difference is something called myocardial reserve. Adults have plenty of it, kids have next to none. To make up for this, a child's heart depends almost entirely on a fast heart rate to move blood, not on how hard it pumps. It also needs more calcium from the bloodstream to function, and it only responds well to more blood volume within this tiny, tiny window. You push it even a little bit beyond that, and you get basically no benefit.
You know, a great way to think about it is like this. The neonatal heart is like a high-performance race car engine that is always redlining. Just to get through a normal day, it's already running at its absolute maximum. So for the anesthesiologist, what does that mean? It means there is literally zero room for error. Any tiny change, any small misstep can push that delicate system right over the edge.
And that brings us to the life support machine, or cardiopulmonary bypass. Now, this is a standard tool in all heart surgery, but for a child, its impact is just magnified massively.
So what is CPB? Well, in simple terms, it's a machine that becomes the patient's heart and lungs. It does all the work, pumping the blood, adding oxygen, which allows the surgeon to operate on a heart that's completely still and empty.
But just look at how differently it's used. The hypothermia? Way deeper in kids. Stopping the circulation? That's common, not rare. But here's the real kicker, the dilution. The fluid used to prime the machine can be up to 3 times the child's entire blood volume. This massive dilution, plus the blood's exposure to all the tubing, triggers a huge inflammatory response throughout the body.
So, how do you deal with these extreme side effects? Well, a really clever technique was developed specifically for this. It's called modified ultrafiltration, or MUF. This is a critical step that happens after the main part of the surgery is done, and it's designed to undo the damage caused by the bypass machine itself.
The idea is actually pretty elegant. It's basically a highly sophisticated filter. Once the patient is off the main bypass machine, their blood gets sent through this special hemofilter. It pulls out all the excess water and those inflammatory chemicals. What you're left with is concentrated, healthier blood that gets returned right back to the patient.
And does it work? Oh yeah. The results are immediate and they are dramatic. As you can see here, just 15 minutes after coming off bypass, the patients who got MUF had a significantly higher blood pressure. That's a clear, powerful sign of better cardiovascular function, which is exactly what these little hearts need at that critical moment.
And all of this leads us to the final, and maybe the most tense part of the whole procedure, getting the child off of cardiopulmonary bypass. This really is the moment of truth.
So the team has fixed the defect, they've used MOF to clean up the blood, but the biggest question is still just hanging in the air. After being stopped, cooled down, and bypassed for hours, is that tiny,
newly repaired heart going to be strong enough to take over the job of running the entire body?
And a lot of times the answer is not right away. And there can be a whole bunch of reasons why. Maybe there's a tiny leak left from the repair, maybe the heart's ventricles are stunned and struggling, or a very common and very dangerous problem, maybe there's a sudden spike in the pressure inside the lungs' arteries.
Now, the solution isn't one size fits all. It totally depends on which side of the heart is failing. If it's the left ventricle that's weak, you use powerful drugs like epinephrine to give it a boost. But if the right ventricle is the one struggling, the strategy is completely different. You have to focus on lowering the pressure in the lungs to make its job easier. It's this incredible, delicate balancing act that requires just immense skill.
Let's just zero in on that right-sided problem for a second. Pulmonary hypertension. See, in a newborn, the arteries in the lungs are extremely reactive. Any little bit of stress can cause them to just clamp down hard. When that happens, pressure skyrockets and the right side of the heart can fail almost instantly. It is a true, life-threatening emergency.
So how do you fight it? Well, it takes a multi-pronged attack. The anesthesiologists use all these ventilation tricks to make the blood more alkaline, which helps relax those lung arteries. At the same time, they're giving powerful drugs like inhaled nitric oxide, which is amazing because it works directly on the lungs without affecting the rest of the body. It's this beautiful dance of clever physiology and advanced pharmacology, all happening in real time.
So, when you take a step back and look at the whole picture, it becomes so clear. Pediatric cardiac anesthesia is so much more than just adult medicine made smaller. It's a completely unique science. It's a field dedicated to managing this incredible tightrope walk between extreme fragility and the profound resilience of the human body, right at its most vulnerable stage.
And that kind of leaves us with a final question to think about. As our surgical technology gets better and better, allowing for even more complex repairs, the challenge starts to shift. The new frontier isn't just about fixing the heart itself, but about how we can better protect the brain, the lungs, and every other developing organ from the unbelievable stress of the cure. And that is the challenge for the next generation in this truly remarkable field.